Dear colleagues, I am Filippo, Crea, Editor-in-Chief of the European Art Journal. Welcome to our monthly dialogue. The dialogues are Socratic conversation among editors, leaders in cardiology, and readers. The dialogues are free and live streamed. Please ask your question because we can receive your question, and please subscribe to our YouTube channel and select the bell to be notified of new content. And now let's start this very interesting dialogue. It is my privilege to ask Professor Tybjærg-Hansen, Executive Editor of the European Art Journal, to start this third dialogue with Professor Yusuf. Anne, please.
Thank you, Filippo. Just a brief presentation of Salim Yusuf. Salim Yusuf is a distinguished university professor of medicine and executive director of the Population Health Research Institute at McMaster University in Hamilton, Ontario, in Canada. Salim is an internationally renowned cardiologist and a world-famous epidemiologist whose work over 40 years has substantially influenced prevention and treatment of cardiovascular disease around the world. Salim has had a more interesting life than most of us, I think. He graduated or got his medical qualifications in Bangalore in India in 1976, and he then received a Rhodes Scholarship and obtained a Doctor of Philosophy from Oxford, during which time he, along with his colleagues, among these Richard Peto and Peter Slate, initiated the concepts of large, simple trials and meta-analysis. Salim holds the Heart and Stroke Foundation of Ontario Research Chair and has received numerous awards and honors. Most recently, in September of this year, the prestigious McLaughlin Medal from the Royal Society of Canada. He has published more than 1,200 articles in refereed, absolute top-level journals, most recently, actually only 10 days ago, in New England Journal of Medicine as first author on the Polypill. Salim currently leads several major global studies involving more than 100 countries around the world, aimed at enhancing knowledge about biological, behavioral, and societal causes, consequences, and approaches to the control of heart disease and stroke. So I'd like to move on to my first question to you, Salim. You have really witnessed the evolution of epidemiology and prevention of cardiovascular disease like few people. So from a historic perspective, what are the main steps or milestones, if you will, in our knowledge of the prevention of cardiovascular disease?
Thank you, Anne. Before I answer that, I want to say thank you and Filippo for inviting me onto this forum. And when I look at some of the names, they're friends with whom I've collaborated over the years, and some whom I haven't seen for a while. So welcome to my friends. Answering your questions, around the 1950s, we realized we were getting an epidemic of coronary heart disease. That's rather than cardiovascular disease, especially in Western countries, Western Europe or Europe as a whole, and North America. And I think the roots of modern day prevention starts with the epidemiological studies, such as the Framingham Heart Study that identified smoking, high blood pressure, and elevated cholesterol. The lipid fractions weren't measured in that study as being associated with cardiovascular disease. In the 1950s, the prevailing theory was this was arteriosclerosis and hardening of the arteries. It was inevitable and it was irreversible. But the discovery of the risk factors, and Framingham was careful to say, didn't mean they were causal, but they were associated. Then over the subsequent decades, we tried to understand whether they were causal. And causality required several lines of investigations. In the basic science lab, in experimental studies, much later in genetic studies, but very, very importantly, clinical trials. Many, many epidemiological studies done in the US, in Sweden, other parts of Europe, in the UK, again showed the same risk factors again and again becoming an important risk factor. I think the real breakthroughs happened in secondary prevention before primary prevention. I think the were 3 or 4 fundamental studies. First was the beta blocker studies, the Timolol study from Norway, the BHAD study from the US, and some of the UK studies showed that beta blockers could prevent death and subsequent MI. And in acute MI, the ISIS studies and the studies from Göteborg, which ultimately became Miami. And I can see Carl Swedberg on the line here. He was involved with OK Hjalmarsson. Then we had the studies with thrombolysis, which is the ISIS and the GC studies were instrumental. And we had done a meta-analysis, Rory Collins, Richard Peter Slight, and I, before those studies came out, indicating exactly the same benefits. So there was a body of evidence coming to that, but it started off in secondary prevention. And then later on, we had the HOPE study in ACE inhibitors and the statin trials, again, for the 4S study from Scandinavia, many, many studies, and the heart protection study. But primary prevention took a little longer. And the key things was repeated studies showing the harms of tobacco, especially the US and the UK physician study by Dahl and Peter, and then showing that even if at the age of 50 or 60, if you stop smoking, you can reverse the risk. Then at the same time, the studies on lipid prevention, as I told you, the 4S and the heart protection study, and then the blood pressure lowering trials done again in Europe and in the US. As you can see, all of this are studies done in Western countries that represents less than 15% of the world's population. And because there was practically no other data from South America, Africa, perhaps even Eastern Europe, Asia, which represents 80 to 85% of the world's population, we just assume that these results could be extrapolated. Now, it was one thing to show that things worked. It was quite a different thing to see whether they were adopted. And so the adoption has been slower. We've had proof, but the adoption into practice was slower. And adoption into practice is not just creating guidelines and telling people this is the right thing to do and this is the evidence, but it is also knowledge translation, implementation science, but very, very importantly, having health systems that can deliver the care. Paradoxically, simpler things are harder to deliver because they don't catch the attention of people. Complicated things like PCI are adopted faster because there's a group of people who are enthusiastic about it and push it. We need both, of course. So we had the risk factor development, the trials, the basic science, which led to many of the interventions. I mean, statins is a superb example of epidemiology, basic science, drug development, clinical trial, and now adoption. We need the whole thing. Now, the field is therefore shifting, as I said, into implementation, into health systems, but now we are learning of a whole new set of risk factors on the environment, and we can talk about it later. So it's an evolution. And in the Western countries, cardiovascular disease mortality rates, after standardizing for age, has come down in most countries by 50 to 60%. And globally, too, we're seeing that. But at the same time, we're having an aging of the population. So we're seeing an epidemiological transition. And in many of the Western countries today, cancer is a commoner disease, cause of death than heart disease. It's not because cancer has gone up much. It's because we've made dramatic decreases in premature cardiovascular disease mortality. Within cardiovascular disease, we're now recognizing strokes are just as common as MI, especially in the older ages. Within MI, the disease has shifted from what we used to call transmural MI or ST segment elevation MI to non-Q wave MIs or non-ST segment elevation MIs with less acute morbidity and mortality, but greater long-term mortality. And we are seeing more and more proportion of milder disease picked up early and treated. So we're seeing a transition between diseases. We're seeing a transition within diseases. I'll stop here. I can go on.
Okay. I'm going to ask you about the Interheart study. You published the Interheart study in 2004 in the Lancet, and you found that 90% of myocardial infarctions are explained by easily measurable risk factors. In fact, by only 9 of these risk factors. Was this your expectation when you planned the study?
Not really. And we thought we'd probably explain 50 or 60%, and that the remaining would be unexplained. In addition to actually trying to quantify the magnitude of the associations, we were very interested in finding out if the associations were consistent in rich and poor countries, and Western countries and non-Western countries, and and also the strength of the associations. And to set up a large cohort studies of 20,000 or 30,000 people in every country in the world is practically impossible. So we took the short route of going with case-controlled studies, which had the advantage of efficiency and rapid answers, and was able to do it at a very modest budget. But case-controlled studies do have their limitations as well. They have the advantages, like it's easy to get a lot of women with a heart attack in a case-controlled study as compared to cohort study, or young people with an MI as opposed to cohort studies. But it also has limitations. You do have first, you can only study what you've measured. Second is you can have more confounding reverse causality, that is the disease changing the risk factors. So case-controlled studies are a useful step. So we understand the limitations of Interheart. We think several of the risk factors are causal. Some of them may not be. Causal definitely are the lipids, smoking, and high blood pressure. More uncertain about some of the psychosocial factors we had. Maybe they are causal, maybe they're not. Glucose as a causal risk factor is still not very clear. Probably it is, but the evidence isn't very clear. So I think Interheart, although we say 90% are associated, that doesn't mean they're causally associated. My own feeling today is causality probably 60 or 70%, and that part of the remaining is just association that is non-causal.
Okay. So what are we missing, do you think, here in the Interheart? Is it genetic susceptibility or unknown risk factors or unmeasured risk factors?
I think we must remember that many of the risk factors we measured in Interheart have a genetic component, like lipids, So I wouldn't say that Interheart debunks the role of genetics. It has no opinion on the matter. But it does say that what we can easily measure has an effect. So what are the things missing? Of course, genetics will play a role. But what we're increasingly knowing is that genetics, the effects of genetics, by and large, can be modified. As we've seen, familial hyperlipidemia, which is clearly a genetic disease, the age of an event or age of death is being pushed out over time. So genetic diseases can be modified. The second thing is there could be risk factors we didn't measure. Okay, that could be another factor. We've traditionally thought of risk factors at the individual level, and that's not unreasonable, but really there are factors at the environmental level. And we're beginning to realize air pollution, water pollution, other risk factors like education. Education is probably one of the strongest risk factors, low education. Is low education simply a matter that people don't know what to do? Or low education a marker of poorer people who don't access healthcare? Or education, again, inherently a protective factor? It teaches you resilience to deal with issues. So it's a psychosocial risk factor. Education really is one of the most important risk factors for cardiovascular mortality. We published that last year. That's been ignored, but the value is we can modify education. That, we can improve education. Temperature is becoming an increasingly recognized factor. We have unpublished data from Pure that shows in the countries where the average temperature is generally low, if the temperature drops further, there is an increase in heart attack and stroke rates. In the countries where the temperature is sort of moderate or high, an increase in temperature by 1 degree increase the risk of a heart attack or stroke by 4%. So imagine what climate change will do, or imagine what heat waves will do. And we know in Europe, during heat waves, elderly people in old age homes, there's a lot of deaths there. And part of it is cardiovascular disease. So I think we're discovering another level of risk factors. Finally, we know social conflicts do cause increased cardiovascular disease. As we found in the Soviet Union, when there'd been economic crisis, cardiovascular disease mortality went up. Now, these risk factors may be working through biological mechanisms that overlap with traditional risk factors, but they are proximal risk factors. So our concept of risk factors is now being expanded into the environment. And is tobacco policy or a lack of policy a risk factor or not? I would argue it is a risk factor. So a country that, so a concept of risk factors is evolving.
Okay, let's move on to a current topic here, the role of inflammation. The positive results of the CANTOS trial with canakinumab and the LOCOCO trial with colchicine suggest that targeting inflammation may reduce the residual cardiovascular risk. What are your thoughts on the role of inflammation in predicting cardiovascular disease?
I think inflammation is a long overlooked pathway to causing atherosclerotic events. I mean, it's been described by Workhoff over 100 years ago, and intermittently we've had work on it. And some very good basic science work has been done on inflammation. So I am a believer inflammation has a role. Is it a primary role or is it secondary to other risk factors? I don't know. For instance, we know with statins, if you aggressively lower lipids, markers of inflammation go down quickly. So I wouldn't be surprised that inflammation is partly independent and partly dependent on other risk factors. And the studies you quote, CANTOS was a proof of concept study, but really it's like the very first generation of lipid lowering studies. It told us there was a signal, but we needed better, more efficient and less expensive therapies. And colchicine seems to be one of those. And our approach to this is sorry, I'm getting calls. I should put my phone away. Colchicine is clearly an option, and we've now had at least two, maybe three studies. The study from Montreal by Tardif, the LODOCO study, and there was hints from smaller studies before. So I think it is something worth exploring in high-risk people, secondary prevention, and we need further confirmation, but I think it's an important pathway.
Okay, thank you. Now, all successful research stories are usually started with disappointments and difficult moments. Is this true also for your successful story? Have there been difficult moments?
If I told you there were none,
you would be lying.
Every successful researcher has had more disappointments than successes. And it's just because when they get knocked down, they stand up and go to battle again. And it's happened to me, more failures than successes. The first failure was I really wanted to be a pediatric cardiologist, not an adult cardiologist. And so when I went to Oxford, I had corresponded with the pediatric cardiologist. I had my project all worked out, which is non-invasive assessment of cardiac shunts. But when I arrived there, the poor professor had a bad stroke and a subarachnoid hemorrhage. And so I couldn't work with him. And so I looked around for supervisors. And then I found Peter Slyton. He was the only one I could talk to. All the other Oxford professors were so high and mighty that I couldn't talk to them. Peter was down to earth, very friendly. And so I said, well, I can at least work with him. But the problem was he was never in the country. So it took a while, but we had a great relationship since 1976. What is it? 44 years till he passed away last month. And we've continued to collaborate. So it was a disappointment that turned into a success. The second one was the first project we did with Peter. It never got published because it was a total failure. It was measuring in infarct size using oral beta blockers in acute MI. And, we did 50 people and we realized the study was too complicated, too problematic, and had too few people. And that's when we contacted Richard Peter, who said, come on, this is crazy. You've got to do studies 10 times bigger. In fact, in the end, it was 100 times bigger and 10 times simpler. And that was a transformation. So it was a mistake that was turned into a positive thing. The other disappointments were dearly held hypotheses not working out. For instance, the magnesium story. I truly believed in it when we tested in ISIS-4. And when we got the results showing no benefit, I was very, very upset for a while. And I said, the meta-analysis in the previous trials could not have been wrong. It's ISIS-4 that's wrong. But then as we worked through the data, we learned why ISIS-4 was right and how even studies of 2,000 or 3,000 people can be quite unreliable. So each of these disappointments turned into positive experiences. Of course, there are professional disappointments of applying for jobs and not getting it, but those are temporary because you overcome it and you always find another job and you make it successful. And within any job, all of us who've held leadership positions have challenges. We have colleagues who we rather hoped we didn't have. we have situations that we wished we handled better. So I can tell you, as Filippo always knows, you call me provocative, Filippo, but with that comes a price. There is a risk that you will upset people. And I'm sure I have my share or more than my share of them. But, it's part of who you are. Each of us is a mixture of our strengths and our weakness. And as one of my best friends have told me, colleagues Herzl Gerstein, Salim, don't dwell on your weaknesses. Your weaknesses are your strengths, and your strengths are your weaknesses. So I think each of us should take our disappointments and our limitations as opportunities to improve and to build from it. And I bet you everybody on this call has had moments they wish they didn't have, disappointments they wish they didn't have, and nobody's had smooth sailing throughout. I can go on, lots more disappointments and successes.
Well, Salim, thank you for sharing with us your wisdom. Today is Thanksgiving. So first thing, I wish our American colleagues, I see Bernard Gersh there, among the others, I wish a very happy Thanksgiving. But this brings me to the question, is turkey a healthy food? Wait, I ask better. What do you think is the best diet based on solid, consistent scientific foundation?
I think the diet story has been a mess. And I think it's been a mess because even the epidemiological studies, the first generation of epidemiology studies really seriously flawed, including the 7-country studies. They were done honestly, but they were seriously flawed with a lot of biases, and data were only presented to reach a certain conclusion. When you re-examine much of the early studies data, it didn't reach it. And when studies, randomized studies, there was a very large trial, or 2 large trials of reducing saturated fats. One from Minnesota, which was the home of the people who did the 7-country studies. It was neutral. It was put away in the basement for 30 years till the son of one of the investigators found it, gave it to the BMJ, and it was published. Similarly, there's been another large trial that's been hidden. So I think our conventional thinking on diet needs to be re-examined. Fat has been vilified. Probably that may not be as bad as we think. And I think some fats are needed. And carbohydrates have automatically replaced fats, and certainly refined carbohydrates and processed carbohydrates. Increasingly, the data suggests they're bad. Equally, I would say low-carb diets, one must be careful. When it comes to diet, we have to remember diet is an essential part of living, okay? So it is likely that for most nutrients, we have a sweet spot. There's an optimal range. Too little is bad for you, too much is bad for you. We can understand that in the context of vitamins, like vitamin A. If you have too little of it, you have vitamin A deficiency. If you have too much of it, you have hypervitaminosis. Similarly, with lots of things, physiology is an optimal range. Physiology is in extremes. Unfortunately, the dietary guidelines have been push your fats way down to the boots, push the salt until it disappears from your diet. That can't be real. Sodium is an essential part of human physiology. We all know that there is something called the action potential, that is a sodium-potassium exchange. So how can it be that we can reduce sodium down to the boots and not have adverse consequences? And the good epidemiological studies suggest U-shaped curves. Diet is very hard to investigate because it's one of the most horribly confounded exposures, and it's a changing exposure. Smoking is easy. Diet is much harder, 20 times harder. Doing trials of diet is also difficult. So my own view on diet is moderation, where you eat a range of foods in moderate quantities. And equally important, I would change diet to eating. Eating is a cultural issue, and eating is a social issue. We do that with family. It's very different than sitting in front of the TV and taking something out of the fridge and eating it. So I would say our view towards nutrition should change. I personally believe moderation and variety of different foods are important. And it is okay to have a little bit of what some people call a sinful food from time to time. I would avoid as far as possible what we call ultra-processed foods. That I would, increasingly data coming that they are harmful. I would avoid a lot of refined carbs, some amount of foods that are fat and animal and are good. The fish data are also mixed. People think fish is the panacea. No, the data suggests it's either neutral or slightly beneficial. And salt, don't consume too much, but don't avoid it totally. So, but most importantly, eat with your family, eat with your friends, and enjoy it. And of course, have a glass of wine, especially Italian wine.
Well, thank you again for your wisdom. Basically, you are saying common sense is more important than epidemiological study, and isolation is dangerous. This was one of your risk factors in the InterArt study. So moderate eating, varied eating in good company is the best recipe. This is the way I'm reading your words. Now, we have an interesting question from the audience. I'm reading is our colleague Uwe Nixdorf from Germany. And the question is about the impact of COVID-19 on cardiovascular disease, both acute and chronic implications. What are your comments?
You know, there are three implications of COVID on cardiovascular disease. The first implication is COVID does have cardiovascular problems. It's a pro-inflammatory state, especially in the advanced stages, pro-thrombotic state, and many of the complications we are seeing, you know, strokes, MI, a lot of the lung disease may be microthrombi in the lungs, damage to the kidney. So there is a thrombotic and other effects on many organs, including the ones we're talking about. Second, there is an immediate indirect effect. The rates of delivery of preventive care and acute care has been set aside because of the COVID pandemic. Patients with class 4 heart failure don't want to come into heart hospital and get treated. I have patients who are terrified and they are short of breath just sitting. Similarly, in the UK, they showed a 40 to 50% reduction in admission for acute coronary syndromes. So there is a problem on the delivery of evidence-based care. But there is also another issue, is some of the unnecessary diagnostics may have gone down, and that can't be a bad thing. But then there is a long-term issue, and the long-term issue is not biological. It's also a diversion of resources, not just from cardiovascular disease, from anything that's non-COVID towards COVID, which means we're going to have, in many countries, certainly in Canada, perhaps in Europe, longer and longer waiting lists for essential cardiac procedures or care. And in fact, preventive cardiology is also, is suffering because people don't go back for their treatments. So there's both the direct and indirect effects. And so really to quantify the impact of COVID, we should look at year-to-year mortality rates from each cause, and we will find at least 30 to 40% of the excess deaths in 2020 during the COVID pandemic is unrelated to COVID, but is due to neglect of care and things in other conditions. And since cardiovascular disease is one of the commonest conditions, we're going to see that. And there have been reports on that.
Thank you, Salim. Next question is about the PURE study. You've been the mastermind of this massive study in 27 countries in 5 continents. Well, what are the key messages of the PURE study in 2 minutes?
Well, PURE was set up because we needed good prospective data from all over the world. So it has lots of countries that have never had cohort data. The second thing is we wanted data at the societal and policy level, see how they affected health behaviors and how health behaviors interacts with genetics to have biomarkers, and how the biomarkers, whether or not they're causal using Mendelian randomization, and then affecting disease. Interacting with it, we also are looking at health systems. What we published from PURE is a very limited part of the PURE data. Our first major biomarker paper came out on ACE2 in the Lancet recently, and we have a series of those being done. We also have health systems work being done. But I think in a nutshell, I'll tell you, 80%, the rates of cardiovascular disease in the low and middle income countries are 2 to 4-fold higher than in rich countries. Our assumption is, therefore, risk factors must be higher in the poorer countries, and the answer is that's incorrect. What we are finding is actually risk factors are lower in the poorer countries, and therefore the WHO strategy of focusing on risk factors alone is inadequate. We have to go beyond. And the reason for that is poor healthcare. Healthcare is important. There is this thinking in some public health circles, healthcare is pretty useless in reducing mortality. No, that's untrue. Healthcare plays a major role. And in these poor countries, their investment in health is low. Like India it puts 1.2% of its GDP on health. And most low and middle income countries put only 2 or 3 or 4% compared to Europe, which is 8 to 10 or 12%, Canada around 12, and the US, obviously, we don't need to talk about it. But so I think Pure is showing that healthcare matters. And the major reason for differences in risk factors between poor and differences in explanation for the higher mortality from cardiovascular disease in the poor countries is poor care. In addition to that, we're now realizing environment matters because what we are finding is air pollution rates, or PM 2.5, is 10 to 15 times higher in some parts of India, in China, and several other countries compared to Western countries like Western Europe, Canada, or the US. And increasingly, I'm persuaded that air pollution has a role in cardiovascular disease. So Pure is emphasizing that the global differences in cardiovascular disease is unlikely due to genetics, unlikely due to, or is only a small part due to risk factors, but a larger part is differences in the quality of care, access to care, and differences in environmental risk factors. And also education. Education is much lower in the poor countries. Sorry, that was longer than a 2-minute answer.
Oh, well, but well done. And also because you have answered the question I've just received from our audience, Filippo from Newcastle, asking about differences between low, intermediate, and high income countries. So your answer is also for him. Now I'm sure that Anne has got other interesting questions for you. Anne, please.
Sure. Salim, in your life, you've been the champion of new ideas, and at times you have also challenged conventional ones, like Filippo mentioned. And I actually think that's something that I really appreciate. But this, of course, has generated controversies at times also. We already touched upon salt intake, but what about another new concept, the Polypill? What do you think about it?
Well, I think the Polypill is a good idea up to a point. The Polypill concept, I mean, in 2002, I wrote an editorial saying, in secondary prevention, we know statins, ACE inhibitors, aspirin, and beta blockers work. So why not put it into a single pill and give it to people? Because there are big gaps in treatment. That doesn't require rocket science. It doesn't require any new trials. It's just a matter of formulation and making sure that you get the effect on risk factors or blood pressure that you expect. But actually, the revolutionary idea was proposed by Wald and Law 2 years later, where they said two things. First, give multiple blood pressure lowering agents, statins, aspirin, and homocysteine lowering, and this will reduce risk by 80% in primary prevention. The second they said is don't measure risk factors, just give it to everybody over a certain age, and they use 50, it could be 55. The first part, if you take the data on folate and all that, homocysteine lowering is not persuasive and we keep it aside. What about the rest? I think that has merit. But the second part of giving it to everybody over the age of 50 or 55 has many challenges. First, the risk of people may be too low. Second, side effects may be too high. Third is there's a social issue. Do we give everybody in the whole population drugs? But I think in primary prevention, there are big groups who are undertreated, like hypertensives. Most hypertensives don't receive a statin or aspirin. Or diabetics. Few diabetics receive multiple blood pressure lowering drugs or statins, even in Western countries. So in those people, I would say people with risk factors, moderate to high risk primary prevention, I would advocate a polypill as a delivery mechanism, okay? And so it makes it easy for people to use it. And or you have to give each one separately, but this is just easier to give it. And that will reduce risk by 30 to 40%, depending on how you look at the data. And that's not trivial. Remember, 80% of cardiovascular events in a community are first events. Out of that 80%, 90% come from three populations: people with hypertension, people with diabetes, and those who smoke. So if you use these three criteria, you can reduce the primary prevention population to about 40 to 50%. And in them, using a polypill won't give you an 80% effect, but could give you a 40% risk reduction. And that means even if you use the polypill in 1 in 3 or 1 in 4 people who qualify by these criteria, you'll prevent 3 to 4 million people getting premature cardiovascular disease every year in the world. That's not trivial, especially when the cost of the polypill is relatively modest, less than 50 cents a day in the poorer countries, less than $1 a day in Western countries. Compare that with some of the things that are being touted today, like the PCSK9 inhibitors. So I think the polypill has a role. And I don't think there'll be a single polypill. There'll be many polypills. And there'll be many polypills with slightly different components. I'd like to see a polypill with a modern statin like Rosuva or Atorva, and with amlodipine, or a modern beta blocker with bisoprolol. And there may be polypills at low and full doses. So already I know of at least 25 polypills around the world, and some of them fulfill these criteria. So I think it's a good idea in part. I wouldn't at the moment give it to everybody over the age of 50 or 55 without having some indication of a higher risk.
Okay. At the end of the day, epidemiological studies, they produce scientific evidence which is or may eventually be incorporated into guidelines. How should physicians look at this evidence, and what kind of evidence is suspicious?
I think, Anne, I think of evidence as coming from multiple sources. The best evidence is when there is a coherence of information from different avenues of investigations. So for me, epidemiological data rarely stands on its own, just like basic science won't stand on its own, or genetics or trials. It's when all these data come together and forms a cohesive story that's the best evidence. We don't often have that. We have that for lipids, for LDL, for instance. We have good basic science, good epidemiology, good trials, and we have registries showing a population impact. That is robust. There are other times where the epidemiological evidence is so overwhelming, for instance, smoking, that we don't need any other data. A 20-fold increase in risk of lung cancer with smoking simply cannot be due to confounding. So these are two examples where in one case, epidemiology stands on its own, and another case, it's a coherence of information from multiple sources. In my own way of investigation, I've combined epidemiology and clinical trials. What I see in epidemiology, I want to, where possible, verify it with clinical trials. I also understand that there are certain times clinical trials have strengths, but clinical trials have also weaknesses. And for example, if we did a trial of smoking cessation and take 20,000 people, half smokers, half non-smokers, at the end of 20 years or 10 years, we won't see a difference. And it's not because smoking is not causally related. It's simply because the clinical trial is a blunt tool in that situation. Diet is a complex issue, and I don't know whether clinical trials are the right way or not the right way. I'm uncertain. I think there may have to be better epidemiology on nutrition, along with some further work in proteomics and metabolomics and Mendelian randomization to understand diet better. Measuring diet in 100,000 people and looking for events has only taken us so far. So I hope future guidelines have been very important, but I hope guidelines will take the totality of the evidence from multiple sources in making a recommendation, and not just epidemiology or clinical trials, but also bring in biology into the thinking.
Yeah, I completely agree with that.
Salim, I have a related question from the audience, from Maria Frigerio from Milan. During this pandemic, we've been overloaded by many papers, and we know that the quality of evidence in this paper not always is outstanding. So her question is, what are simple rules to distinguish what is good from what is not good? And she goes further. Do you have suggestions for editors-in-chief?
Well, think of the COVID situation being like the 1960s situation in cardiovascular disease. We did not have this disease a year ago. We did not know much about its etiology, its complications, its epidemiology, and it's evolving. The remarkable thing is how much information has come through. While we can look at each paper and say, well, it has serious flaws, and they do, many of them, they're important contributions. They were done rapidly, under incredibly difficult circumstances. And as long as the data are honest, and we know some of the data that have come out are not honest, like that famous Lancet publication, which is preposterous, I would say editors should publish it, because even if what they show has limitations, they advance knowledge. The trials, most of the trials done have been underpowered. There have been only 2 sets of trials that are reasonably powered, which is the recovery trial from the UK, which is a remarkable achievement, and the WHO Solidarity trial. Unfortunately, after testing 5 or 6 interventions, only 1 intervention, dexamethasone, seems to stand up, and that too in the more advanced disease, but not in the milder diseases. And this may be real, because in the milder disease, it's viremia that is the main issue. In the later disease, it's inflammation, thrombosis, and secondary complications. So obviously, a steroid will work late, but not early. Similarly, it's possible antivirals might work early, but not late. So yeah, I think we're learning. I would not advise editors to put some moratorium on certain types of studies. I think you just have to evaluate each one of its kind. But I think the comment made had an implication that many of the studies being published are not as high quality as some of our other studies in other areas, but other areas are more mature. So I think we have to look at it as what is the gap that study fills. If it fills a gap, we should publish it.
Thank you, Salim, for these suggestions. And I have a final question for you. What about the future of the EHJ Dialogues like today? What are your suggestions?
Oh, gosh, it's often said predicting the future, predictions are difficult, especially of the future. So my suggestion is there will be quite a few wonderful people you can interview with varied life experiences, and certainly do them. But I think you should go beyond, and you've got to ask yourself, where are the biggest burdens and challenges in cardiovascular diseases? They are in the poorer countries, in the developing countries. And I would urge you to bring in leaders from those countries who, with huge odds, are trying to overcome those challenges. The work I've done could simply not have been done had I lived in and worked in a poorer country. It's just the environment helped me. So do interview key people from the poorer countries, South America, Africa, Asia, and others. Also, the disease patterns in these countries are different. South America, Chagas is important. Africa, rheumatic heart disease, peripartum cardiomyopathy, endomyocardial fibrinoelastosis, and there are other kinds of nutritional diseases. Incidentally, our data suggests that in the poor countries, it is undernutrition that causes cardiovascular disease, not overnutrition. Okay, so you want to think about nutritional deficiencies as a cause of cardiovascular disease. So as you choose the topics or people, think of the global picture of cardiovascular disease. The other part of it is, what do we need to overcome the disease burden? You need to think of experts in health systems, because it's health systems that will translate it. Now, the European Heart Journal hardly published the paper on health systems. Maybe it's time to at least publish one or two every few weeks. But bring in experts on that, and they'll tell you how you integrate it. And in the West, especially in Europe and Canada, we have we have universal healthcare. The countries that don't have universal healthcare have a greater burden of cardiovascular disease, or they have to spend a lot, like the US, to control it. So bring in topics about the role of universal healthcare. What is it? How can it have an impact? Because that has a bigger impact on cardiovascular disease than finding a new molecular pathway. So broaden what cardiovascular disease and interventions is, to environment, to health systems, to health policy, to the developing countries. The developing countries, incidentally, are the majority of the world. So that would be my humble advice.
Well, Salim, I thank you for your humble advices. As you know, the mission of the European Heart Journal is global. We have co-editors from 5 continents. And actually, we discussed this before, and I thank you because you gave me some excellent suggestions. So the mission of the journal is definitely global. Well, this concludes our dialogue today. Thank you, Salim, for your wisdom and for sharing with us your time. Thank you, Anne, for leading this important dialogue. And now it's my great pleasure to remind you that the next dialogue, exceptionally, will be on Tuesday. Will be on Tuesday, 29th of December at 5 CET. Not on Thursday, because Thursday will be 31st, and we want to leave you with your families to celebrate the new year. So the next dialogue, please put it in the agenda, will be on December 29th, will be a Tuesday at 5 CET. Thank you again for your participation, Salim, Anne, and the wonderful audience I can see in front of me. Bye-bye.